Welcome to Primary Focus. I'm your host, Dr. Tara Kiran. I'm a family doctor and a researcher, and I created this podcast to launch a conversation we really need to have about how we can deliver primary care to more people across our country. Today, part 2 of our series on Costa Rica. If you missed part 1, I suggest you go back and enjoy the really dynamic conversation I had with Boston-based physician and researcher Dr. Madeline Pesek. She laid out important background and context for this on-the-ground look at Costa Rica's primary care system, one that's been built over decades, and one that consistently achieves more than its resources would predict. She's also the person who introduced me to a local physician leader, one who became my volunteer guide on my trip to Costa Rica. Here's her telling me more about the wonderful Luis. Yeah, tell me a little bit about him, because you know him, and I met him in Costa Rica, and he was such a gracious host. He drove actually several hours with his team to meet me, and then we drove for another hour to go to the EBAIS, and then we spent some time there. So tell me a little bit more about Luis.
Luis, I met, and I think I just showed up in his office, and he made time and space for me, and we talked for 2 or 3 hours in the middle of his workday. I'm sure he had 100 other things that he had to get done. But alongside being a lead of the region, he is incredibly focused on how do we leverage data to do the right thing and to do the right thing consistently. And so he serves a health region that historically was quite underserved and has worked to improve their health metrics and health outcomes substantially with him. And I believe he is working on his PhD or just finished his PhD, again, in this pursuit of knowledge and using evidence to grow and get better and do better for his people in his region. This is someone who hopefully you'll hear some audio from him. You can just feel.
Oh, yeah. There's lots of audio for him, because also one of my weaknesses, I don't speak Spanish. So he was like the translator for me the whole time. Yeah.
Well, I hope audiences can feel the love. One of my role models was Dr. Paul Farmer, and he used to end every consult note that he would write in the hospital. And he would say, "With love, infectious disease." And it just struck me that what you see and what you felt and hopefully what listeners will hear is that love, and that love for patients and the love for the work and for his country and for this incremental improvement to every day do it better than we did the day before and use every tool in our belt to marry this very quantitative, rational analysis with love.
Digamos las que existen, porque ahorita nosotros tenemos Jicaral Islas que tiene como 14,000.
Luis and his colleagues picked me up right from my yoga retreat center in a large black SUV. We drove through small villages and countryside along a very potholed road to get to the clinic Luis wanted to show me.
Turn left on Calle Bocas de Nasara.
Each area have so many EBAIS.
Yes.
So el área de salud, Nasara, ¿cuánto EBAIS tiene?
No.
Nicoya.
Área de salud, Nicoya.
Okay. Nicoya.
The clinic we're heading to is on the Nicoya Peninsula. It's an 80-mile-long peninsula on Costa Rica's Pacific coast, just south of the border with Nicaragua, and it's home to many pristine, isolated beach towns and wildlife refuges, and yoga retreats. It's also a part of Costa Rica that's made headlines for its high proportion of centenarian residents. According to one BBC article, 3.5 times the global average. Here's Luis.
Nicoya is the health area. This EBAIS, Nosara, is one of the EBAIS from
In the
area.
health area.
Exactly.
Yes. There are 140 health areas, right? Or something in Costa Rica, something like that?
105.
105 health
exactly.
areas?
Exactly.
In 7 regions, I think, right?
Exactly. That's great. That's great.
I was reading.
As we talked about in our last episode, Costa Rica is broken up into 7 health regions, and then from there into about 100 health areas. Health areas are responsible for disease prevention, community health education, home care, and primary care delivery for between 30,000 and 110,000 residents. Each health area's size is dependent on both the geographical needs of the population and the regional capacity. Each health area has on average about 10 EBAIS teams. Now, I want to tell you what EBAIS stands for, but I'm a little worried I might pronounce it wrong. So here's Dr. Madeline Pesek instead.
The EBAIS teams stand for the Equipo Básicos de Atención Integral de Salud. And so what that translates to in English are the basic healthcare teams for the holistic provision of health.
Like we talked about in our last episode with Madeline, EBAIS are integrated primary healthcare clinics with team members who serve the local population. Residents are assigned to the local clinic based on where they live, and on average, a single EBAIS clinic serves about 4,000 people. In the area that we're visiting today, there are actually 2 EBAIS clinics.
Right there is 2 EBAIS.
There are 2 EBAIS
Exactly,
here?
for around 7,500.
Okay.
He starts to work 7 a.m. to 10 p.m.
The EBAIS is open 7 a.m. to 10 p.m.
Exactly.
Yes.
It's open.
And you said there's 2 of them.
Yeah, exactly.
Side by side.
Side by side.
Who exactly works at these EBAIS clinics?
Yeah.
Okay, the thing is, 1 doctor,
Yeah.
1 nurse auxiliary,
Yeah.
1
Pharmacist, right?
pharmacist,
Yeah.
and 1
Luis says that in addition to the doctor and the nurse, there's also a pharmacy technician and a medical clerk. Someone who creates the agenda for the doctor for the day, but who also analyzes the clinic's data and pulls together chronic condition registries. And one more important role.
Yeah.
and 1 ATAP.
And that's like a health worker.
Assistant, exactly.
Yeah.
From what Madeline told us in our last episode, these ATAPs, or
Asistentes técnicos de atención primaria, which means that they are the primary healthcare technical assistants.
thank you, Madeline, they go out to residents in the community.
Yeah, and I'm very interested in especially the role of the ATAP, the health worker.
Okay,
Yeah, and how that works with the doctor and nurse, like how
Okay.
they work together. That's because that's a unique role. It's not one that we have in Canada. I
Okay.
think it's quite unique as
Okay.
well.
so let's go.
Let's go.
During my visit, I speak to a doctor at the clinic about how their role is different than the doctor's role in a lot of other health systems, like the one here in Canada. While at the clinic, I also spoke to a nurse and the receptionist, and because the pharmacy is integrated within the clinic, the pharmacy technician. You're not going to hear those interviews, but I'll work my insights from those conversations into the tour of the clinic. Canada is a much richer country than Costa Rica. When you adjust for cost of living, Canada has about twice the economic resources per person compared to Costa Rica. And that makes Costa Rica's primary care system all the more impressive. Because where Canada has the money, we lack the system. In Costa Rica, they've got the system, but they don't have the monetary resources we have. These are not the bright, white, institutional-looking clinics that you're used to. The buildings here, they're made from exposed concrete. Their infrastructure, it's crumbling in spots. And most of them are painted what Madeline called institutional caja blue, or the signature color of the Social Security Administration. The clinic I'm visiting today has that caja blue bordering the building, but I should mention that the exterior walls are actually kind of a pale mustard yellow. Here's Louise giving me a very quick tour.
Right now, you have the pharmacy over there. It's the medical record registry, and this is that.
Inside, the clinic waiting room is very busy, but it's also clean and organized. The clinic walls, a lot of them are ivory in color, but there's also lots of caja blue. And it's mid-November, so that means there are a lot of little Christmas decorations everywhere on display. And in one room, there's even a Finding Nemo mural painted on the windows. It's here that we meet Dr. Rosales.
Ok, bueno, mi nombre es José Javier Rosales, ¿verdad? Yo soy prácticamente oriundo de Santa Cruz.
Dr. Rosales says he's from Santa Cruz and that he finished his studies in San Jose in 2022. He spent some time working in emergency rooms in Santa Cruz before he came to the clinic. Today, he's wearing dark blue scrubs, and I guess he's in his late 20s or early 30s. He talked to us while sitting at his desk next to a green curtain that he can pull across to add privacy to the exam room.
He's Dr. Rosales. He's worked at 7 a.m. to 4 p.m. At the first. He says he has around 3,500 patient.
Okay.
Okay, eso es lo que tienes como población.
That's a lot.
What he said probably is a little more, that we have uncounted this kind of people. We don't 100% sure about this, the people who have that to cover.
Yes. So So it's about 3,500, but it
Each
could be
one.
more.
Exactly. With team.
As you heard, this clinic serves about 3,500 patients. The clinic has 2 doctors, and between them, they staff the clinic from about 7 a.m. to 10 p.m., 6 days a week.
Okay, and do you switch? Sometimes you do afternoon?
No, porque
You're always doing the morning?
todo el tiempo en la mañana.
Dr. Rosales says their schedules are fixed, and they don't really rotate who's on daytime and who covers the evening.
So the other doctor doesn't ever get to have dinner with his family?
No, probably
es
not.
muy difícil, ¿verdad?
Dr. Rosales has the morning or earlier shift. When I spoke to him, he just started working at the clinic a few months before.
Exactamente, en la mañana.
Is it hard to find a doctor who will work 4 to 10 Monday to Friday and 3 to 10 on Saturday?
Es durísimo. Duro no, durísimo.
It's really hard.
Yeah.
Me voy a sincerar con usted, es muy duro. Y el tema, digamos,
He said
distancia.
the work in the evening or the afternoon or even at night is really hard because they have the public system to how to carry the patient from here to the hospital to Nicoya is a...
Hora y 30, 2 horas.
You mean they don't have transport for
Exactly.
the patients, so if they get sick,
Exactly.
the doctor has to transport
Yeah.
them?
En
Yeah.
rojo,
If have
hora y
any
10
patient
minutos.
is critical, a critical condition,
Oh.
you have to go to the patient, to go to the hospital and back to here to work.
Oh, wow.
Sí, es duro, son por lo menos 3
And
horas.
they
y-
drive themselves, or they have,
No, they
a
have-
driver,
no,
but they
the
have
driver.
to go with the driver.
Exactly.
There's no ambulance.
In ambulance.
Wow.
At the private ambulance privada,
Cruz Roja Costarricense.
at the Cruz Roja, the Red Cross,
Sí.
they have to take here the patient, go to the hospital, and then when they deliver it, back to here.
Whereas when you're the daytime doctor, that doesn't happen? You don't have to go in the daytime, it sounds like. It's only the nighttime doctor that does that?
No hay nadie.
Okay.
Se le explica a los pacientes que es lo idóneo, ¿verdad? Para
Oh,
que ellos
because there is a
entiendan el por
service.
qué.
There's like the public service will do it during the day.
Exactly.
Got it. But in the
Now, in Canada, this is not how it works. At my practice, and most others, we take turns covering evening shifts. But here, if you're on evenings, it seems you're on evenings every night. A little side note. In our podcast episodes about Costa Rica, we're talking about the public system, which is there for everyone in Costa Rica. There is, though, a parallel private system that's supplemental and could provide more personalized and faster access to physicians and tests. It's used, for example, by people with a higher income who can pay privately or for people who have employer-provided health insurance. I asked Dr. Rosales why he chose to work in the public clinic over one of the private clinics we drove by on the way here.
He said it definitely is the advantage
en lo
to
personal.
work to the public system.
Oh, okay. What's the advantage?
Hay que tomar en cuenta el sector público,
Yeah.
tenemos son los asalariados.
Okay, he said we have a lot of advantage to work in the public system because we have month by month your salary. You have
Yes.
to social security. You have any kind of
Benefits.
Exactly.
Yeah.
They will if you doesn't work in the public system.
Right. So most doctors prefer to work in the public system.
Yeah.
Y en privado, usted va a depender de...
Now, Dr. Rosales, he refers to himself as a general physician. General physicians have done a medical degree and a short internship, and then they can start work in hospitals or EBAIS clinics. You could go further, though, and become a family medicine specialist, but that's another 4 years of supervised work-based training, much like a residency here in Canada. There are, though, very few family medicine specialists in Costa Rica. They largely act as clinical and system leaders within each health area. Most of the doctors in the EBAIS are general doctors. Now, Dr. Rosales says he sees about 32 patients a day. Most of those patients are coming in to see him because of a chronic condition, like high blood pressure, diabetes, or asthma. But he reserves about 6 slots for urgent issues, people with fever or diarrhea, or children who are sick. But he says even though they're supposed to be open for acute issues, they often fill up with patients who have chronic conditions.
Sí, eso lo maneja la compañera y normalmente ella me dice, doctor, ¿estamos llenos? O,
Here, he says often his colleague who makes the schedule will tell him, "Doctor, we're full," or "There's no space." And then he needs to squeeze them in on top of his full schedule. Or if it's an emergency, he needs to treat it that way.
To look for any space for any kind of patient, you have to include over there in the gym. He don't control it over there. He have to work for
Vamos a esperar a
This is the goal.
sustitución,
Yeah.
a sustituir.
Can I see your agenda? Is that okay?
Claro que sí. Vea por acá.
Here, Dr. Rosales shows me his schedule. he has maybe one spot open this afternoon, but then tomorrow there are only 5 patients booked in his schedule. But he says the slots always end up filling up.
9 a.m.
Right.
And then, que todavía me falta.
So you have some free spaces after 1 p.m.?
The care Dr. Rosales is offering at the clinic is largely for people with chronic conditions and acute issues. That's similar to much of the work doctors in Canada do. But here in Costa Rica, there is a big difference. The first point of contact is actually the community health worker, or the ATAP. In this clinic, Dr. Rosales says while he sees patients when they need him, he doesn't really know them. He's not from this community, and all the ongoing relationships built with patients, well, they're built with the ATAP. Dr. Rosales, he meets with the ATAP only once a month, unless there's a specific case they need to discuss.
How does a patient know when to see you versus the nurse versus the ATAP?
Es muy importante, muy importante.
It's really important to try to...
Inclusive es muy importante porque yo me apoyo en ella.
He said he's following him for this place, that it's really important to adapt.
La auxiliar de enfermería.
He has the medical information, very important information for the patients.
Como tal. Sí, es
So the ATAP knows all of the people.
Yes, exactly.
And he or she tells them to come to see?
Yeah, exactly.
In general, most of the pre-booked patients for Dr. Rosales have actually been referred there by the ATAP because they have a chronic condition or, for example, they're pregnant. The ATAP play a unique and critical role in Costa Rica's primary care system, one that's integrated with public health and that serves the entire population. Coming up, we'll meet the ATAP team Dr. Rosales works with. In this clinic, there are 3 ATAP that go out into the community. Luis says they mostly travel by scooter or motorcycle, and then by foot. This role, for me, is what makes this system so unique. Not just that the community health workers go out to the patient, but also that it's done with this population-based approach.
Which are these? These are within Nosara, the different areas that the ATAP cover?
Yeah.
Okay.
Los Ángeles, Rio Norte, Garza.
In the clinic, there's actually a wall covered in maps of the Nosara area this EBAIS covers. Next to it is a large whiteboard with a list of vaccines and how much stock of each is in the clinic. And because the ATAP work outside of the clinic most of the time, I was just hoping to catch one of them at this visit.
He said the 3 ATAP is here.
Oh, wow. 3?
Yeah.
Okay. My lucky day.
Yeah, exactly.
Luis said they're all here today because they're working on a census, a study to get more accurate numbers on the real population that lives in the area. The ATAP say in COVID, when they stopped doing home visits, more people moved into the region, and as a result, they don't have clear numbers anymore. And so Luis and I got to sit down with Angelina, Kainer, and Eric to talk about their work in their community, again with Luis playing translator. These ATAP have a goal every day of how many houses they need to visit, though Angelina says it's sometimes hard because the family might not be home or might turn them away.
I would love to know, what you do on a typical day. So what you did yesterday or what you're going to do today.
In this EBAIS, the ATAPs are each responsible for visiting about 1,500 patients multiple times a year. Their work is assigned based on the color-coded maps I mentioned. And they each have a digital tablet with their agenda and access to the integrated medical record for each family that they see. At the end of each day, they make an agenda for the next day with a goal of how many homes they'll visit tomorrow.
Okay, he said the agenda is made about around 15 homes. But, so actually he said is normally, he have to time to attend 8.
Okay.
But the agenda is about 15.
And so you just put in the region you want to go, and they will. Does the computer prioritize it, or does it just give you like 100 and you pick which 15?
Va en orden.
Because it looks like it gives you a lot of homes there.
¿Cómo saben? Vamos a identificar casa por casa.
Aquí está el mundo, ¿no?
Okay.
El código de la
Each
casa.
home or each house has
Yeah.
a number,
Yes.
and he said that is the agenda is made about as the number of the house.
Okay. So that they are close together.
Exactly.
Okay. And you can see the last visit date here too?
Puedes revisar la última visita que hiciste o puedes ver la visita que le hicieron a esa casa. Oh, he said it's possible.
And does that factor into which homes he's going to? Like he goes to the ones he hasn't been to in a long time, or?
Ahí queda registrado y sale qué usuario.
Based on this system, homes are rated either as a 1, 2, or 3 level of risk. No matter the risk, the ATAP are expected to visit every home at least once a year. But if they're considered a risk level 1, they're visited 3 times a year. A risk level 2 gets 2 visits. And for a level 3, the goal is 1 visit a year.
Are these the factors that?
Yeah, these are pregnant without control, teenager pregnancy,
Okay,
child
maybe I'll just take a
under
picture
6
of
years.
that.
Exactly.
Yeah.
In the home, the ATAP, they can administer vaccines, take blood pressures, check sugars where necessary. Luis says they also look for women who are what he calls pregnant without control, meaning they've not yet been checked by a doctor during their pregnancy. The ATAP, they might also do checkups on the children in the home, and as they work, they're filling out a form for the family in the medical health record on their tablet. You might remember in my interview with Madeline, she recalled seeing a piece of paper on the outside of people's homes where ATAP logged their visit. This is now done digitally through the electronic medical record. And as mentioned, the ATAP might refer someone in the family with a chronic condition or pregnancy to Dr. Rosales or the night shift doctor back at the clinic. When they visit a home, they also do education with whoever is there about staying healthy and supporting people in the home who have chronic conditions. They might also offer education on topics like violence against women or substances, if those are relevant to the home. All 3 of the ATAP I spoke to say more and more violence and drugs are a part of their work.
Yeah, what is one of the most challenging parts of your job?
Aquí no será que no le metan un embarazo.
He said violence.
Violence.
Shouldn't.
Which?
Shouldn't.
Wow.
It's really violent because drugs, narco traffic.
Wow.
Sí.
Wow. And so, does it happen when you were on a home visit or you were?
No, pasa siempre como en la noche, en la madrugada, pero igual ha pasado en el día.
Yeah.
So frequently it's at night.
El diablo de limón.
Angelina, ¿y para usted cuál serían los principales retos que tiene su trabajo?
Visitar ese sector.
He's a little bit scary about they go to a specific place or specific region that has a higher level by violence.
Oh, okay. Then that's hard. What,
Violence is escalating in Costa Rica. In December 2025, Costa Rica's ombudsman sounded the alarm on a deepening crisis of violence against women, with femicides hitting a peak not seen in over a decade. And, like Angelina, Kainer, and Eric say, there's also been a big increase in violent crime driven by gang warfare over drug trafficking. And though this gang violence seems to mostly affect big cities, the ATAP at this clinic say it's happening in their communities too. You can imagine how escalating violence might make these community health workers a little more reticent to knock on doors. He says there is some weight attached to letting people know you're an ATAP. The residents, they have a lot of respect for the work that ATAP do.
What is one part of your job that you really love?
Bueno, algo bonito que me queda a mí siempre es.
When I asked this question, the ATAP had big smiles on their faces. And then they started telling us stories about some of their favorite patients.
He said they're really grateful to try to invite people without no control, any kind of control. Like he said, experience about 2 adults, 78,
Por ahí.
78 years old, and never came to here. They have a really huge fungus about their arm, and he invited him to came to receive medical attention. So when they left, they buy some kind of chicken for the close to Christmas. And that's really
To say thank you.
Le pagamos
for
un taxi
helping him?
porque queda muy largo y es un cerro así.
Yeah.
Wow.
This
Did
kind
you
of stuff.
bring him?
Angelina says she loves taking care of older adults. She says they often tell her that no one comes to visit them, and so they're excited to see the ATAP because the ATAP listen to them and offer some companionship.
Resume. She said that it's a lot. She's really like adult patient, so it's really sad for her when the patient pass away.
It's very
go to
sad
visit.
when they
Exactly.
and they've gone over. That's sad. Yeah.
These ATAP, they say their job is not just about illness. It's about the relationships they make with the people.
Today is my last day here in Costa Rica. It's a small country, but it is a country that had vision and ambition. So even though Costa Rica is a country with fewer resources, I think there's a lot that we can learn. They share that value of every person in the country having access to primary care. And so we have a system here that is not just about delivering medical care in a clinic, but really integrates primary care together with public health, health promotion, and disease prevention in a way that's very community grounded. And with primary care at the center of what they do, they're able to achieve outcomes including lower infant mortality and longer life expectancy. So I think there's a lot that we can learn here about a population approach to primary care and integration of primary care into community. It's what the people we spoke to through our care wanted to see. We just, I think, need to set the ambition, just like Costa Rica.
Okay, let's talk about Canada. Now, here in Canada, there are actually some communities where we have people who do work similar to the community health workers in Costa Rica. We'll hear more about them in upcoming episodes. Sometimes they're called community health workers, but sometimes they're also called community ambassadors or cross-cultural health brokers. And they play a really important role, especially in high-priority areas. But an important difference is that in Costa Rica, they take a population-based approach. The ATAPs know everyone in the community. In fact, it's their job to know who is living in the community and what their situation is like. Much of the time, people in the community, they don't need to go out and seek a doctor's advice. The ATAP come to them and refer them to the doctor when that's needed. To me, this gets at another really important issue: the integration of public health and primary care in Costa Rica. This goes back to decisions made decades ago that there should just be one government agency responsible for primary care and public health. That means they can move in a unified, wellness-oriented direction. When they invest in keeping people well, the same agency reaps the rewards of lower healthcare costs down the road. That's not the same here in Canada. Our primary care system and public health system, they're separate. And yeah, they may refer to each other and try and collaborate, but ultimately, what happens in public health, it affects a different bottom line than the pot of money used to fund primary care. For example, in Ontario, public health units are run by the city, while healthcare delivery is a provincial obligation. Public health, they focus on vaccine and specific health promotional activities like breastfeeding, child development, parenting, and preventing harm for people who use drugs. But these are often delivered in a silo from what's happening in primary care. Our information systems aren't connected, and we don't really know what one another does. Let's say a patient of mine gets a vaccine at a public health clinic. I don't get a notification, and it's not added to the patient's electronic medical record. That leaves it up to the patient to let me know the next time they see me that they've received that vaccine. Public health units, they don't even have a list of the doctors working in the region. That became a big issue in the pandemic when they were trying to communicate about really important updates. If doctors signed up to their newsletter, they'd get those communications. But if not, there was no way of reliably reaching the doctors practicing in the area. Those are just two examples of how our communication systems don't work with each other and how we're really operating in silos when it comes to primary care and public health in Canada. Ultimately, I go back to that 2017 paper in Health Affairs, where Madeleine Pesic and Asif Biton, talk about the 4 pillars of the Costa Rican primary care system: integrating public health and primary care, geographic empanelment, so covering the entire population in a community, strong interprofessional teams, and robust data feedback loops to track outcomes and ensure the system is meeting its goals. Of course, the Costa Rican system isn't perfect. From both Dr. Madeline Pesic and the people I spoke to in Costa Rica, I heard a lot about how the system has been slowly eroding due to underfunding, a challenge common around the world. But even under strain, Costa Rica achieves better outcomes, lower infant mortality, longer life expectancy than their spending would predict. In fact, according to data from the OECD, Costa Rica's life expectancy at birth is higher than the United States and on par with countries like Germany and the UK. For me, the lesson for us is clear. We have the resources. We just need to find the ambition to design a system that puts primary and community care at the center and ensures every single person is cared for, no matter where they live. I'd really like to thank a lot of people for their help with this episode. A big thank you to Dr. Madeline Pesic for all her help bringing this 2-part series to life, and for introducing me to Luis Carlos Vegas Martinez, who served an incredible double duty as guide and translator. I very literally could not have made this episode without him. Also, a big thank you to Luis's colleagues, Dr. Eddie Apoy and Juliana Monje Aguero, who joined us on the car ride and clinic tour and offered their expertise along the way. And to everyone in this EBAIS clinic who let me interview them, including Dr. Rosales, Angelina, Kainer, and Eric. Primary Focus was created by me, Dr. Tara Kiran, and is made possible by funding from the MAP Center for Urban Health Solutions, St. Michael's Foundation, and the Max Bell Foundation. Miriam Danash is our research assistant, Seema Marwaha and Emily Holton are our creative advisors, and our producer is Avery Moore-Kloss. If you'd like to read more content from me about Canada's primary care system, join our Substack newsletter at primaryfocus.substack.com or visit our website, primaryfocus.ca. For more information on the Our Care Standard and the public's vision for a better primary care system, visit ourcare.ca. Family doctors in Canada who are listening to this episode can claim MainPro credits by completing a linking learning exercise. See the show notes for more information. And finally, if you're enjoying this podcast, I hope you'll share it in your networks. It's only through enlarging the conversation about primary care in this country that we're ever really going to affect system change. And if you have cool ideas for topics or places I can visit and feature in our podcast, please do reach out at primary.focus@unityhealth.to. The information shared in this podcast is for educational and informational purposes only. It's not intended as medical advice and should not be used as a substitute for professional medical care, diagnosis, or treatment. Always consult with a qualified healthcare professional before making any medical decisions or changes to your health routine. The views expressed in this podcast are those of the speakers and do not necessarily reflect the views of any organizations I may be affiliated with. Side effects of listening to this podcast may include a strong impulse to help fix the primary care crisis in Canada, a feeling of anger over how many Canadians do not have access to primary care, increased feelings of empathy toward primary care professionals who are just trying to make it work, and intermittent visions of hope that we can find a better way.